morning to everyone to this revision session of EDIC 1. This will start from 11 a.m. We are like 5 minutes behind, and this will go on till 7 p.m. And we'll have breaks in between of 15 minutes. The first session will be taken by Dr. Rakesh Periwal, and the topic will be obstetric emergency. Thank you.
Thank you. So we will just revisit what we had discussed the last time, and I will present it in terms of the physiological changes first, because a lot of times queries are asked about what are the changes, and these can be divided into cardiovascular, renal, respiratory, salt and water metabolism, endocrine, and hematologic. So if you look at the cardiovascular changes, there is peripheral vasodilatation resulting in a 25 to 30% fall in systemic vascular resistance. The cardiac output increases by about 40%, mainly due to an increase in stroke volume. But this should be remembered. We know that the contributor to the cardiac output is both the heart rate and the stroke volume, but the predominant mechanism by which the cardiac output increases is by an increase in the stroke volume. The heart rate also increases. It's usually by 10 to 20 per minute, and it also assists in the increased cardiac output. There is hemodilution with about 1 gram decrease in hemoglobin levels. So the anemia cutoff comes down by 1 gram%, and venous return can decrease by about 25% in the supine position. And that is why we ask these ladies to lie in the lateral position. If we have to resuscitate an individual, supine is the favored position. But in pregnancy, the uterus in the supine position presses upon the aorta and the IVC, which increases the afterload and decreases the preload respectively. This can compromise the cardiac output. So left uterine displacement is a valuable maneuver, either by manually lifting up the uterus by 2 hands or by placing pillows below the right head. This is a standard procedure which is adopted when giving CPR on a pregnant lady with, who's near term. You do the left uterine displacement. What are the changes in the kidneys? The size increases about 1 to 1.5 centimeters, and that's obviously because of the increased blood flow. Creatinine decreases to 0.4 to 0.7. This is very interesting because the normal level of creatinine in pregnancy is much lower. And when you have to define renal insufficiency, this has to be kept in mind. Renal plasma flow and GFR both increase more than 50%. The renal pelvis and ureter are also enlarged. Sometimes the entire picture on an ultrasound may look like a hydronephrosis. This is all because of stasis and enlargement in size. There is predisposition to urinary infection, and because of which asymptomatic pyorrhea is also treated in pregnancy. There is impaired glucose reabsorption, so some amount of glycosuria is expected, and the protein excretion may also go up. The cutoff here taken is 300 milligrams a day. And entire pregnancy is a state with relative resistance to angiotensin II. Respiratory, generally there is a respiratory alkalosis, obviously because of the increased rate of breathing, and some of it may be contributed even by the hormonal milieu. There is increase in the oxygen demand because of both the fetal needs and the rise in the basal metabolic rate. 40 to 50% increase in minute ventilation, with major contribution to tidal volume increase. So here also the rate increases, but the contribution is mainly by the tidal volume. And in cardiac output, it was the stroke volume. Elevated diaphragm later leads to decreased residual volume, but tidal volume remains okay. So in later pregnancy, the chest cage becomes a little smaller in size, and that is why the residual volume decreases. The maternal hemoglobin dissociation curve moves to the right. That means it wants to carry the oxygen. It doesn't want to deliver the oxygen to the tissue. But as soon as it goes into the fetal circulation, the curve moves to the left. So there is offloading of the oxygen. So the fetal oxygen curve moves to the left. There is preferential offloading of oxygen, whereas the maternal one moves to the right. So you can say the mother first wants to give the oxygen to the baby and then only use it for herself. What about salt and water? Vasodilation with underfilling activates the renin-angiotensin-aldosterone axis and the sympathetic system, and there is also activation of the AVP system. The plasma volume expands by around 30 to 40%. and the RAS activation leads to elevated aldosterone. Vasopressinase is released by the placenta and counter the effects of vasopressin. So overall, you have a vasodilated state, you have a hemodilated state, you have an increase in the total body water, and there is excessive activity of the RAS. Thyroid, there is raised thyroid binding globulin, and it elevates the total T4 and T3, but usually the free T4 and T3 remains normal. Beta HCG mimics TSH because both are glycoproteins. And sometimes when we have these beta HCG levels which are elevated, it can lead to clinical features of hypothyroidism. And this is more common in cases where the beta HCG levels are very high, like in molar pregnancy. There, almost the clinical picture can be like that of thyrotoxicosis. There is relative iodine deficiency, and the intake should be doubled. And normally, goiter doesn't form during pregnancy. Adrenal cortical hormones also increase. There is enlargement of the pituitary due to lactose hypertrophy. And this is especially relevant when people have pituitary tumors, especially a prolactinoma, because its size is going to increase during pregnancy and requires monitoring. FSH and LH are almost undetectable because now you don't want an ovulatory cycle. We know that the amenorrhea also extends to almost 6 months after delivery of the baby. And this is because the FSH and LH have almost no activity, and they come to activity in the late lactational period. What about insulin and glucose metabolism? There is resistance to insulin due to maternal hormones. Placental lactogen is one of the hormones implicated. Fasting blood glucose is lower due to increased sugar consumption, uptake by the fetus, reduced hepatic glucose output, and increased storage of tissue glycogen. So the cutoff for diabetes also changes because of this physiological change. Gestational diabetes, 100-gram glucose loading test is what is recommended, and the respective cutoff for fasting 1, 2, and 3 hours are 95, maximum goes up to 180, 155, and 140. So begin with 95 and end with less than 140. So fasting blood glucose in double digits is what is desirable in pregnancy. And this we would generally do it at 24 weeks of age. Macrosomia is weight more than 4 kgs and an abdominal circumference more than the head circumference. So these are the two criteria which are used, and this can cause difficulties in delivery of the baby. Fetal hypoglycemia and diabetes is very common, and this is because of the increased circulating levels of insulin, and this should always be considered in the immediate period after delivery. Hematologically, there is hemodilution, there is mild thrombocytopenia, generally would still expect it to be more than 1 lakh. Prothrombotic states with rise in fibrinogen, decreased fibrinolysis, and elevated clotting factors with reduced activity of protein C and protein S. So overall, pregnancy is a prothrombotic state. The most common acquired thrombotic disorder in any individual is factor V laden, and we know that it has correlation to OCP use and thrombosis. And in pregnancy, one of the acquired coagulation defect which can be of great significance is the antiphospholipid antibody syndrome, where you have the recurrent fetal losses and thrombosis in pregnancy, two most important components of APLA. Commonest cause for thrombosis in pregnancy is factor V laden, and it is because of a single gene defect in factor V, and it makes it resistant to action of activated protein C. Protein C usually inactivates factor V, which is a procoagulant and participates in the indirect pathway. And here it might be difficult for the activated protein C to work on factor V. So you have a resistance to APC. These are two indices which are talked about, shock index and the pairs. Shock index is the ratio between heart rate and systolic blood pressure. A ratio of less than 0.9 is favorable, whereas a more than 1.4 indicate the need for urgent intervention and stabilization. Pairs is for preeclampsia, It's an integrated estimate of score, which takes into account the platelet count, the creatinine, the LDH, the AST and the ALT levels. And then we have also the obstetrically modified quick SOFA score. I don't know how much SOFA will be in vogue in time to come, but this is one of the scoring systems which is unique to pregnancy. Now we talk about the specific diseases, and the most lethal one, among one of the most lethal one, is acute fatty liver of pregnancy. It is more common in primary and likely have heterogeneous long chain 3-hydroacyl coenzyme A dehydrogenase deficiency. The LCHAD deficiency is what is generally implicated, characterized by elevated liver enzymes and bilirubin, elevated P time with decreased fibrinogen, hypoglycemia, and anyway, we know pregnancy, the risk of hypoglycemia is much greater, as we had already outlined in the pathophysiology, and rarely there could be acute liver failure. The liver shows microvesicular fat deposition. Otherwise, the fatty liver, which we see in obese patients or as metabolic syndrome, the type of fat deposited is called macrovesicular, but here it is microvesicular. And another classic example of a microvesicular fat deposition is the Ray's syndrome. Delivery of the fetus is a solution, so that should always be considered. What about health? It is defined with a platelet count of less than 1 lakh, an LDH of more than 600, and an AST/ALT more than 70. But sometimes you can have some part of it only. So that is called a partial health syndrome.